The data showed overwhelmingly that nurses have a much higher rate of suicide than other occupations. And if women were 50% more likely to commit suicide than other occupations, and males were over 40% more likely to commit suicide, like attempt suicide with than other occupations.
Better to have a short life that is full of what you like doing than a long life spent in a miserable way.
Hey. All right. So let's back this up because Sarah, I'm sorry to break it to you, but I'm gonna have to hold on to you for just a little bit. Okay.
All right.
So let's talk. Let's talk about, you said in the beginning of that answer that you were most recently, I don't know if it was just because you were giving a lot of lectures on this or talking a lot to these conferences about this, but let's talk about nursing mental health, because another one of my nursing news stories that I have recently done is that nurses, their suicide rate is much higher than the regular population.
Yes.
And in that specific study, I know because there's not a lot of men in nursing, it said that the female suicide rate is much higher. And just anyways, suicide rate is much higher. So let's deep dive on this mental illness, mental health, and just burnout in nursing.
Okay.
What's the main issue and how are we fixing it? How are you going about it?
The study you're referencing is from UC San Diego, and it came out this year. And it's a really monumental study because it basically took the data of a bunch of information from surveys that people fill out based on their occupation, and then compared certain aspects of their answers from occupation to occupation. So nurses, they took a bunch of information and they stratified it out, and we're like, okay, let's just look at the nurse answers compared to the electrical engineers and the people who work in offices and all these other careers. They did that for 1 year, and they only did it for a few states. So it's a very limited batch of data, but the data showed overwhelmingly that nurses have a much higher rate of suicide than other occupations. And it was over 50% for women are likely to commit suicide, and over 50%, women were 50% more likely to commit suicide than other occupations, and males were over 40% more likely to commit suicide, attempt suicide with than other occupations. So we're talking really high numbers, not 5%, 10%, whatever. So it's a very limited amount of data, but they've applied to expand the amount of data they're going to get access to by many folds over. So in the next year or two, we should have a lot better, larger sample size of data coming out. But this early in data and results are very concerning, right? I'm a female nurse, and I definitely don't want to be 50% higher likelihood of attempting suicide. Okay, so that's the first piece of that. So the second piece is we all are nurses. We all know we're stressed. We're overworked. We're being asked to do more and more with less and less. Are we getting the support we need to process what we're seeing every day? Are we getting the support we need to do the things we're supposed to be doing every day? What is the nature of our work? Is our work just filing papers? Well, for some nurses, it might be. For the vast majority of us working bedside, we're interacting with people, again, sometimes during the worst times of their life, or people who've been seeing horrible things for a really long time. And so we're absorbing all of that. We're supposed to be emotional support for others, but what's the emotional support for us? So we are getting increased stress. We're having horrible compassion fatigue. We're facing burnout. In the ER alone, they have one of the highest rates of turnover in any nursing specialty. And there was a study that came out a couple of years ago that said, on average, an ER will turn over its entire nursing staff every 5 years. Yeah, that's the face. That's the face you should make. That's the face you should make. We are hemorrhaging ER nurses. And in other units, in other specialties, it's similar. AACN has all this data about burnout in critical care nurses, progressive care nurses, telemetry nurses, med-surg nurses. We're all facing really high rates of burnout. And I think we all kind of know why. And they're just now starting to research it. So we now are getting evidence-based results, our research-founded results of astronomical rates of PTSD, of stress, of fatigue, of burnout in nurses across the board, right? Okay. So this is the reality of where we are in America. We have a very high pressurized healthcare system helping people who don't have access to the things they need. They're very sick. We're giving our heart, mind, body to these things. We're physically suffering. How many nurses? I always start like a presentation with, imagine your coworkers. Now imagine coworkers and say, who there is complaining about backache, headache, shoulder pain, couldn't sleep last night, I'm tired, I'm going to the gym this week, or I'm on a crazy fad diet that's supposed to help me decrease my weight because I'm just stress eating all the time. Okay. We're thinking about everybody that we work with, right? And the problem is, the healthcare culture changes slowly. Healthcare systems are going to change slowly. There are now trends to look into how we can help our nurses from a facility standpoint. But what we as individual nurses have to do is realize what we need to do is take care of ourselves, and that we can't take care of others if we don't take care of ourselves. There's overwhelming issues with depression, anxiety, panic disorder, and suicide in nursing, and it's real. And one of the problems is we're not talking about it. We love to complain about what's wrong with our jobs, but we don't like to talk about how we're feeling about things. And there's a huge stigma around, can you be a successful nurse, a good nurse, if you have mental health challenges or if you're struggling with your mental health? I have a long history, and I'm really open about it with depression and anxiety. I've been really low at times. I'm on medications every day for antidepressants. I have a rescue medicine that I take for panic attacks, and I see a therapist. And that, together with a lot of other things, has helped me get to where I can still be an ER nurse almost 10 years in. It'll be like 9 years next year. And I can successfully say that I've been through some of the hardest moments of my life in my career with the support of many multi-pronged approaches of treatment. Evidence shows that people who commit to self-care will have better outcomes with their mental health. People who commit to exercising, to eating well, to sleeping well will have better mental health outcomes. But our jobs aren't setting us up for success in the things we need to do. So we have to recognize what we need to do and move forward with that. And what I really like to focus on in my efforts with New Thing Nurse, in the talks I give and the workshops I give, is advocating for an open conversation. So I have a new lecture I just started called Nurse Mental Health. Let's talk about it. And the reason we need to talk about it is, one, we need to talk about it to decrease the stigma, which is a huge conversation around mental health in mental health care, medicine, and everything anyways. But specifically to nursing, we need to end the stigma that you can't be a good nurse, or you can't be a ER nurse, so you can't be a critical care nurse if you're depressed or if you're anxious or whatever. We're very cowboy about things. If you talk about that you're sad or scared or nervous, like, you're looked down as weak. And we have to take that away. We have to stop that right now. We also have to start being supportive and checking in with each other, because we are losing our coworkers to suicide. We are losing them to substance abuse. We are losing them to other jobs that might be easier or less stressful, because they are not getting the psychosocial support they need to stay in the ER, to stay in critical care, to stay in med-surg, wherever it may be. And we also aren't reporting it data-wise. So when they're trying to do research now on mental health and nursing, but they will send out thousands of surveys, often these researchers will, and they'll only get like 100 back, because we are underreporting. We aren't comfortable even filling out an anonymous survey to tell people about it. And so by us not talking about it, we're like perpetuating the cycle of underreporting, no data. The facility's not going to change anything if they don't have data. We don't have evidence-based practices. We aren't studying it. And we're also limiting ourselves in how successful we can be, because we're not talking about it and being supportive of each other. So what I really want to do is, like, one, just tell people it's okay to talk about it. Like, I'm a successful, good ER nurse. I'm a really great ER nurse. Some days not so much, but some days I'm a great ER nurse, and I'm on antidepressants, and I have a therapist, and I've been sad, and I will be sad again. It's not like it ends just because I'm on drugs. I will continue to take them and have to go up and down on my meds, and it just depends. And I think the other piece is that we have to recognize what we have to check in with, what we need, and we have to empower ourselves to tell people what we need. Like, hey, I need to talk about it. Hey, I need to take this day off. Hey, I need help over here because I'm sad and starting to freak out at the bedside. We need to be able to take those moments and have those open conversations and not fear societal repercussions of looking at us as weak or inferior or incapable of doing our job.
Wow. Just wow. Look, listen. I have so much to say about this, just because, look, Look, so the way you're talking about it is literally, and I hate when people say things like this, but it really is like a paradigm shift. It's like literally like you're trying to change the culture. You're not trying to change a task. You're not trying to change like, oh, this is something extra you can do on your day off. No, you're trying to change the culture. And if you just switch, I mean, listen, y'all, I mean this in the most respectful way possible. But if you just switched I'm talking about professional, like nurses as a profession, to toxic masculinity, it's crazy how much of that is like, it's similar, because I feel like it's so crazy to me. It's crazy to me to say that, but yes, at work, sometimes I feel like people are going to think of me less if I say I need help with my med pass today. I feel like people are going to judge me if I say that patient that had a fall, it wasn't my patient. I couldn't control whether they fell or not, but it made me feel some type of way. And I need to go sit down and either vent or cry it out. It's so much, Sarah, it's so much. But you're right. The culture needs to change, because as much as us nurses like to complain about it, we are not trying to fix it. Like, there's not, like, you never hear that conversation about like, okay, so how can we fix this issue? No, we just bitch and moan all day, because that's what we do at the nursing station. All right. So, okay.
Well, I will say that just on an optimistic note, there are nurses working on this, and there are people trying to research it and advocate for change. And there are people, I think, even in every unit who are starting these conversations and trying to figure it out. There's things, even institution-wise, that are coming out that show people are aware of our needs. There's something called a code lavender, which you can call, which is almost like a code gray. If like someone's feeling like I can't emotionally handle my job right now, there's some facilities that have an actual code response team that show up to emotionally support the nurse. Like, it is amazing. And take them out of bedside staffing for a little bit and try to help them out. There's something called the medical pause, which was developed by a critical care nurse in, I want to say, Virginia, who after a patient passes away and there's the code effort and everything has been stopped, in the moment at the bedside, all the staff that want to participate can take a moment of silence to honor what has just happened, to honor the person that just passed away, and process what they just went through. And there's also critical stress incident debriefing. And that is where you get together like 48 hours after the event, a stressful event, traumatic event, and kind of go through and like a group setting, kind of what happened, how you felt about, and all these things. So and these are evidence-based practices that help show that it's helping us process and be more successful, healthier people, healthcare staff in the future. So there are things happening, but they are slow. But if you think that those are things that would help you at your facility, go and research them. Find the studies that are out there, find the evidence, and take them to your leadership and advocate to try these things, because that's part of us being bedside nurses and advocates for change. We have to take this on, because if we're waiting for the facility or society or the patients to take this on, we're going to be waiting until we're old and gray. And I already started dyeing my hair, so we got to get on work to try to shift all this now, so that it's not when we're old and too old and damaged to be able to take advantage of it.
And I respect that. And I love that. But again, I really want the actual actionable, things, right?
Yes.
So yes. I need you to tell me, has any of it actually worked in your practice? Give me the honest answer. Don't BS me, Sarah. I want the honest truth. Have you done any of those things, and has it actually helped you?
Yes. So my focus with pediatrics, one of the most traumatic things I have found that I see in the ER is pediatric death. And so that is something that is devastating. Like, if you go through that and you're there, part of the code response, you are an amazing being and you are strong beyond measure. If you can get up the next day, drive home that day, I mean, it is one of the most emotionally devastating things that can happen to you. So what I have done, the debriefing process, and it has helped me infinitely in those moments to get together with my team and be able to talk, cry, discuss what we did, how we felt. It's not a moment to do case review. We're not going through and be like, we should have done this and we should have done that, and maybe this would have changed the outcome. No, it's like, I felt this in this moment and I feel this now. And I need, and being able to identify with my community and be like, I'm not the only one struggling has been infinitely helpful in those moments. I also take a lot of time to now advocate for the time I need. If I feel that I'm getting buried under a very stressful assignment, I am very vocal in communicating with my leadership. So my charge nurse, my flow nurses and things like that, to be like, listen, this is really hard. I'm going to need some help. I make sure I take my breaks, because if I don't take my breaks, I don't get that time to process things. If I'm having a bad day, I'll take a walk outside if I can. I work day shifts, so I have, the light out and I can do those things. I make sure I eat. They sound like little things, but just being able to pee is kind of a luxury. Like when I got to California, I was like, I get to sit down and eat food and take a moment in the bathroom. Like I would work 12 and a half hours in Georgia and I would shove a power bar in my mouth and keep going. And I was 25, so I could do that. But when I got to California, I really got to actually take care of myself so I could take care of other people. And my mental health has been so much better because of it. I went through a period where I was really burnt out. I wasn't sleeping. I had insomnia. I was on sleep aids. I was having super horrible anxiety and really bad depression. And by adjusting my personal practice with a lot of these aspects and other things, in addition to therapy and medications ultimately, and switching shifts. So I got off night shift and went to day shift because I personally always struggled sleeping during the day. But even admitting that to myself, that I can't hang on nights, that was how I looked at it. I'm weak. I cannot be a good nurse because I can't hang at night because I couldn't sleep in the day. And that was just how my body was. But when I finally even got to the point where I forgave myself for wanting to switch shifts, that's where I was in my mental confusion. I was so much better. I was sleeping at night. I was rested, and just those basic things of being able to eat, sleep, pee, you're a different person. And then once you can go beyond that and really do the things you need to do, it can be a life-changing experience, and definitely a practice-changing experience.
Congratulations, Sarah.
Yes.
Oh, no. But I really do mean that, at a personal level, congratulations, because that is huge, right? That is huge.
It was big, and it took years, and it's still an ongoing process. And that's what I like to remind people is it's not like I'm here and will always be here. It's an up and down forever,
So just to push on that just a little bit, where have you found, and it's nice, I don't want to say it's easier, but it is nice that there is the policy that you have the ratios where you're at. But where did you find the most pushback when you were trying to develop these everyday things for yourself to have better health? Where did you get the most pushback, and what did you do to overcome that?
So I think a lot of it's around the culture of nursing, even being hey, I need to take my break, to the break nurse can often be what do you mean you need to take your break? I'll tell you when you need to take your break. You get a lot of that kind of pushback sometimes, not always, but sometimes. And I think just being more proactive about my communication style has been really helpful. So saying, hey, if I come in at 7, hey, I would really love to take my first 15 at 10. If you can put me down on your list, that would be great. And I usually take my lunch at 1. And then if I could step away for 5 or 10 minutes at 5, that would be great. And just being proactive in that way. Because the most pushback I get is that when you ask for something in the moment you need it, and it's something I need to go take a break, it's often looked on as a sign of weakness. You want to step away because you're a quitter is kind of the general feedback you get. But nurses are practical. They're logical people. And so I think sometimes what we need to verbalize in our communication with our colleagues is sometimes a care plan. What I need is my care plan for the day, and I need you as my break nurse to know it. So my care plan will be approximately at this time I need to go take a break, and then this time I need to take a lunch, and then I also will need a 5 or 10 minute situation in the afternoon. And once they go, okay, and then they get used to that, and I advocate for that every shift, people don't give me any pushback anymore because they're just Sarah's that nurse that likes to take her breaks. And by doing that, I like to think that hopefully I can empower other people to also say, hey, maybe it's okay for me to take my breaks. Because sometimes you just need to find someone else to know that you're not alone, that I also would like to eat my lunch. I would also like to use the bathroom. That would be amazing. And not to feel as if you are different. Because if you feel like you're different, you're not going to ask for those things. And I think that can sometimes be the biggest catalyst for change, is just having more than one person speaking up.
Okay. So last question on this, but I think it's super important, and that's why I keep pushing. But what advice do you have for those nurses that don't have break nurses, that aren't in California? Like when you do go on your tour, your talks, what do you tell those nurses? Because literally, those words coming out of your mouth was the first time I've ever heard of a break nurse. So what advice do you give to everybody else?
Okay. So first, medicine is evidence-based. We go with the numbers. So you need to pull up the studies that are most applicable to your community and your setting. So if you're in the emergency room, it's most helpful to pull emergency nurse
studies,
burnout studies, right? Or break studies or fatigue studies. And you have to figure out what do you want? And then what is the thing that fixes? And then what are those data points that might be being collected? Because sometimes you might be like, I need more breaks, but I don't know how to advocate for that. And then I'm like, okay, go find a study. And they're like, well, what do I look up in the study? Like, what do I look up and where do I look up? So I think having resources of where to go to find studies, what are the words and terms that people are using? Because the research terms are very different sometimes than what we would normally talk about. Also bringing that data to the right leadership. So, your CNO might not be the person you want to hear this because they might not actually be the people who can affect change. You want to start with people who are really going to have buy-in. Charge nurses are great people to start with. Unit-based counsel, nurse managers, nurse educators. Educators love data. They love research. And then move up to your director and higher up levels. And often correlate it with how the things that healthcare facilities love is how patient outcomes are going to improve and how they can save money. And if you can find the data and that ties in with breaks make patient outcomes better, which ultimately save you money, you have a conversation in a language now that they're really going to listen to, right? It's great to hopefully go to leadership and say, the wellness of our nurses is suffering and we think we need breaks because it would really improve staff satisfaction. But let's be honest, that's not very compelling. But if you can go up to them and say, you're going to save money annually, X amount, because patient outcomes are going to be better. Nurse retention is going to be better. How much you spend on hiring and training new people is going to be better. Workers' comp cases. So if your occupational injury rate is going to go down because you have better staffing and better breaks, those are the things that they're going to listen to. And so finding the right people and the right talking points is the key piece to really affecting change in your facility, I think. Because you don't even need legislated ratios. This is just common dollars and cents, which they're really into.
Yeah, dollars and cents is what, management and above. If they have that name, management, and there's someone above that name, that's all they care about. No, I'm lying. It's not all they care about. It's not all they care about, all right? Because patient safety, everyone cares about. But it's a lot of what they care about. So if you have research, and you're right, nurses are logical people. And so it makes sense to us as well. But it would, okay, all right. Let's leave that there because it is some legitimate, fantastic advice. And I love that. And I love that you allowed me to push back on you.